Hello everyone, this is Dr. Moada, and today I'll talk about GI history taking. So let's get started. So the abdomen is composed of 9 parts, as you can remember, and the GI system is composed of 2 parts as well, the alimentary organs and non-alimentary organs. The alimentary organs are organs related to food like esophagus, stomach, biliary, duodenum, ileum, jejunum. And the non-alimentary organs are liver, spleen, pancreas, and gallbladder. Let's review some anatomy. I will start by the surface marking of the abdominal organs, specifically the non-alimentary organs. So the spleen underlies the left 9, 10, and 11 rib. Posterior to the mid-axillary bladder is located at the tip of the 9 costal. The pancreas, as you can tell, has 3 parts: the head, tail, and neck. The neck is on the L1 level, while head of pancreas lies below and right, and the tail of the pancreas lies above and left. To palpate the upper border of the liver, you need to ask the patient to fully exhale and then palpate the 5th right intercostal space. In order to reach the lower border of the liver, you need to tell the patient to fully inhale and then palpate the mid-clavicular line. Talking about the kidneys, they lay deep to the 12th rib posteriorly. Right kidney is 2 to 3 centimeters lower than the left, as the liver lies on the right. In order to take your patient history, you need to start by asking them about their personal details. In moving to the GI system, you need to ask them about the common symptoms, like diarrhea, functional dyspepsia, IBD, IBS, maybe vomiting, anemia, anorexia, and more common symptoms. I will go over these common symptoms in this video. Starting from the mouth, you need to ask your patient if they have noticed any bad breath, dry mouth, or altered sensation in tasting. Another common symptom is anorexia, which is losing your appetite over food. This usually comes with weight loss. If the patient is losing less than 3 kilos over the 6th month, you do not need to worry. Always refer to the records of the weight to compare the patient's weight. If the patient loses more than 10% of their weight over the past 6 months, you should consider reduced energy intake from dieting, losing of appetite, malabsorption, and malnutrition. Other diagnoses may be increased energy expenditure, like in hyperthyroidism. If you have noticed any rapid weight loss over the past days, you should consider vomiting, diarrhea, or using diuretics. If your patient is complaining of painful mouth, you should consider sore lips, tongue, or deficiency in iron, B12, or vitamin C. Another diagnosis may be chemotherapy or dermatology disease, or maybe infection and inflammation. If your patient is complaining of heartburn and food reflux, your primary diagnosis should be GERD, gastroesophageal reflux disease. This happens when the lower esophagus sphincter is dilated, allowing the acids to go up to the esophagus. About the site of the pain, characteristics, maybe what's the relieving factor, maybe food is relieving them, or NSAIDs. You should ask them about associated symptoms like nausea, vomiting, belching, and bloating. We will come to this later, but for now, if your patient is complaining of early fullness, indigestion, and maybe bloating or nausea, you should consider functional dyspepsia as your first diagnosis. Structural dyspepsia is not common and it needs further investigations. To classify dyspepsia, you need to think of associated symptoms. So if it's associated with heartburn, it's probably a reflux-like dyspepsia. If it goes or relieved on food, you should think of ulcer-like dyspepsia. If the patient is feeling early fullness, bloating, and nausea, you should consider dysmotility-like dyspepsia. Note that fat intolerance is common with all causes of dyspepsia. If your patient is feeling pain on swallowing, you should consider odenophagia as diagnosis. It is caused by esophagitis or esophageal ulcer or yeast infection of the esophagus like candidiasis.